Now, I would like to introduce our speaker for this morning. She is a OBGYN specialist and vice chair of the department at Northridge Hospital Medical Center. Please welcome Dr. Heidari.
Good morning. Thank you so much for that warm introduction. I'll go ahead and share my screen. I'd like to take a moment and say thank you so much to the Tzu Chi Medical Foundation for sponsoring this lecture and for joining us this morning and my talk on discussing cervical and breast cancer screening. So thank you to everyone who is here today with us on a Saturday morning in a very hot, sunny Southern California. And for all of those who are listening not locally. So the purpose of this lecture is to discuss cervical cancer screening guidelines and recommendations, outpatient procedure that examines the lower anogenital tract, to identify abnormal lesions for possible biopsy. And we've assumed to have a near perfect sensitivity for testing. However, recently this has come into question. A more realistic detection rate for cervical neoplasia, also known as cervical cancer, after abnormal cytology has been about 70%. And we'll also go into breast cancer screening guidelines and recommendations, discuss a little bit about breast tissue density and the implications of COVID-19 vaccination in breast cancer screening. What is cancer? Cancer is the name given to a collection of related diseases. In all types of cancer, some of the body's cells begin to divide without stopping and spread into surrounding tissues. Cancer can start almost anywhere in the human body, which is made up of trillions of cells. So we'll focus a little bit more on the gynecological cancers, cervical cancer, and breast cancer today. What is the cervix and what is cervical cancer? So as I previously mentioned, the cervical cancer is abnormal cells of the cervix. And here, I think if you can see my pointer, the cervix is located here. So this is the vagina, the uterus, okay, also known as the womb or what carries the child. You have the fallopian tube and the ovaries. So here you'll see cervical cancer screening really involves focusing on that lower aspect or lower organ known as the cervix that is attached to the uterus. The reproductive system is a group of organs that work together for sexual reproduction. And as I mentioned, it includes the ovaries, fallopian tubes, uterus, cervix, and vagina. But for the purpose of this lecture, we're going to focus on the cervix and screening of the cervix for cervical cancer. So when we look at overall incidence of cancer, there's a couple of statistics that I want to focus on. One is the risk of developing a cancer. So what's your chance or risk of getting the cancer? And then the second is what's your risk of dying of the cancer? So, you know, people more commonly kind of, I think, hear maybe about pancreatic cancer as one of those cancers that, you know, have a higher risk of unfortunately dying from that cancer. So when we look at breast and cervical cancer, you see here that the risk of developing breast cancer is 1 in 8 women inside the United States, whereas the risk of dying from this cancer is 1 in 39. Okay, and part of the reason that there is a discrepancy in this and that the risk of dying is low is we try to screen women. And we'll go into a little bit about the recommendations for screening for breast cancer as well as cervical cancer. Whereas here, the risk of developing cervical cancer is 1 in 159. So a much lower risk of developing cervical cancer. And I think in part is the push for screening. So that's very important. And so we recommend, you know, every year going to the gynecologist's office not only for a physical exam, and we'll get into more of this in later slides, but when do we screen for cervical cancer? What age do we start? And what are the factors that may adjust or account for changes in screening? And part of the reason that we're so aggressive in screening for breast and cervical cancer is because for cervical cancer, it can be curable. And so the risk of dying from this cancer is much lower than breast cancer. So the risk of dying from cervical cancer is 1 in 455. And when you look at the lifetime probability of developing cancers for females, and this is a little bit older of a statistic, 2013 to 2015, you'll see breast 1 in 8, and uterine really doesn't make some of the top lifetime probabilities of developing the cancer, which is good news. That means that our screening efforts inside the United States have been hopeful. So when we kind of look at some of the more recent data and statistics put out by the CDC and the cancer organizations, we see worldwide that the incidence of cervical cancer in the world is about 4 amongst the most common incidents of gynecological and cancers in the world. Where in the United States, we're talking about ranks 13. So a little bit less common of an incidence, and this may be attributed to our screening efforts. And so you'll see again that correlation with death and worldwide versus the United States. So the incidence and mortality probably ranking very similarly worldwide, whereas in the United States, again, a much more lower mortality rate noted. So we briefly discussed in our purpose that we wanted to look at evaluation or examination and how does this occur for cervical cancer. So cervical cancer is a clinical diagnosis, and we make this by actually looking during the physical exam and visualizing abnormal cells. And one of the ways that we can do this is by a colposcopy. So this is where the physician will take or the provider will take a special microscope and look at the cervix. And they may use different medications or techniques to visualize and evaluate the cervix for abnormal cells. And they may even take a biopsy, so taking a piece of tissue and sending it to the pathologist so that they can further evaluate for abnormal cells and cervical cancer cells. This is typically done in the office setting. And when we look at the anatomy of the cervix under the microscope, there are some specific areas in which the provider or physician is looking at. And part of this has to do with where do we find these abnormal cells. So our focus is on the transformation zone. So this zone of tissue here, and typically this zone changes with age. And so as we get older and as the cells become more mature, they internalize and go from an external location to more internal location. And so you can see kind of where the original zone was and how that becomes the new zone with time. And part of this differentiation has to do with, well, when we evaluate the cervix, we also take into consideration our patient's age. And so through the different stages of life, you can see that our cells are regrowing and regenerating. And so these zones and areas will change with time as well. The American Cancer Society estimates that for cervical cancer in the US, there'll be over 14,000 new cases of invasive cervical cancer diagnosed. And this is pretty significant, especially because we do such a, I think, good job inside the United States for screening. And so I think part of the purpose of this lecture is to encourage patients to contact their medical center and schedule their appointment to get their pap smear in order to screen them for cervical cancer and precancerous cells. And about 4,000 women in the United States will die from cervical cancer from the American Cancer Society. And so I think a big portion of this lecture will be into educating what is involved in physical examination and what the purpose of screening with a pap smear for cervical cancer is. So cervical precancer cells are diagnosed far more often than actual cervical cancer. And this is very important to mention. I think a lot of patients have a lot of anxiety around their pap smear, but remember, pap smears are a screening test. They're the first step in determining, are the cells abnormal or do they look normal? Okay. Cervical cancer was once one of the most common causes of cancer death in American women, but because of the pap test, the cervical cancer rate has dropped significantly. And so this is a huge plus for American women and women all over the world. And this screening procedure can find changes in the cervix before cancer cells develop. It can also find cervical cancer cells early when they're small and very easy to cure. And sometimes biopsies are sufficient enough to remove these abnormal cells. Again, a female in her 30s, this is typically what her cervix will look like. And you can see in the lower aspect of this screen, kind of that zone or that circular circumferential area around the cervix. And this is an example of kind of a normal cervix for a female in her 30s. And here I've just posted to illustrate some abnormal findings and some findings of cervixes that may not look so normal. And so you can kind of compare and see the difference when we look under that special microscope, that there are some more abnormal findings. You'll see, especially in this picture, some abnormal findings. All right. When we look at the rate of cervical cancer, you see that over time, so the lighter blue line is the incidence of new cases. And so you can see since the 1970s that you can see that trend, that line of cervical incidence of cervical cancer really decreasing over time. And over, I would say, the last 10, 20 years, see more of a leveling off. So since 2007, more of a leveling off. And part of that is due to, we'll see in a few slides, the progression of screening and testing and how far medicine has come in detecting cervical cancer. Whereas the death of cervical cancer really has remained stagnant over time, in part because our mainstay treatment for cervical cancer has been pretty consistent over that period of time. Where are we seeing cervical cancer? Where are the trends and disparities in the United States? We see higher rates of cervical cancer in Black and Hispanic women and women living in non-metropolitan areas, so more rural areas and more lower socioeconomic areas. And part of that has to do with access to care and access to screening. So in non-metropolitan areas, it may be difficult for patients to go to their doctor's office. Transportation may be challenging. Also, insurance may be a factor, and the ability to be screened. Women who have never been screened or haven't been screened in 5 years have also significantly higher rates of cervical cancer. And one of the recommendations of the American College of Obstetrics and Gynecology is to see your OBGYN physician or see your provider every year for routine screening and routine health maintenance. And depending on your own medical conditions, you may need to be seen sooner or later, but typically, even in healthy women, we typically see or recommend to see our patients every year. And with COVID and the pandemic in the last year and a half, almost 2 years now, we've seen patients now kind of been holding off for their annual, in part because of some of the real concerns of COVID-19 and trying to minimize our exposure. So what causes cervical cancer? The human papillomavirus accounts for 99% of cervical cancer. And so this is a double-stranded DNA virus and has more than 120 closely related viruses. And many of these strains can cause genital warts, cancer of the throat, cancer of the cervix, cancer of the anus, cancer of the vagina. So there's a number of cancers related to the HPV virus. It's typically confined to the epithelium, so that layer of tissue that we discussed and that I mentioned kind of in the earlier slides of the cervix. And these cells regenerate and they reproduce. They're not typically killed. So one of the concerns and many questions that I get from patients is that I have HPV, can I cure it? And HPV stays with us for life. Right now, unfortunately, we don't know of a cure for HPV. Our body can fight it off and can suppress the virus so that it's actively not regenerating or causing reactionary changes leading to cancer. But in terms of curing it, unfortunately, at this time, I'm unaware of a cure. There is vaccination for HPV in the United States, and it targets 9 of the most oncogenic or cancer-causing types of HPV. 2 of these types cause more than 90% of genital warts, and 7 of these types included in the vaccine cause more than 80% of cervical cancer. So there is a vaccine that can prevent cervical cancer. And part of the reason that you see these trends decrease over time inside the United States is a push and a vaccine that has helped support this decrease. And so many of the cancer organizations have pushed for vaccination information to be disseminated in the community in order to educate our community on availability for cancer prevention. HPV infection is common. Many reports show that over 80% of men and women in the US have HPV and they don't know it. It's very prevalent in the population. And here by the CDC, they note almost all sexually active persons will acquire HPV. However, I think depending on who you read, that statistic may be closer to 80 to 90%. And in the United States, approximately just shy of 80 million infected new infections per year will be detected, and 14 million new infections per year will be documented. Genital HPV is first acquired soon after the onset of sexual activity. About 40% will be infected within 2 years. So infection is usually transient and asymptomatic, meaning that you may not even know you have it. And over 90% of the infections will clear within 2 years. Your body will be able to fight off and suppress the virus. So cancer is a rare outcome of an HPV infection. And part of educating the community is to educate on prevention and health maintenance, in part with a pap smear and screening for HPV. Now, how does HPV virus go from HPV to cervical cancer? And this requires a persistent infection. So an HPV infection that's not clearing. And part of the ability for us to detect that is coming in every year or coming in, well, as your doctor recommends, to be screened for HPV and to follow up persistent infection if in fact you do have it. So HPV's initial infection targets the normal cervix, and typically we see clearance of this HPV. An HPV infected cervix will show mildly abnormal cell changes. And over time, if this progression persists, you may see precancerous lesions. And so on that colposcopy that I had illustrated a few slides ago, where we evaluate the cervix under the special microscope, we can see these persistent changes and persistent HPV infections with that microscope, biopsy them, and detect these precancerous lesions before we see invasive cervical cancer. The peak incidence of precancer we see in the late 20s, and we see the peak incidence of cancer in early 40s. That's not to say I haven't seen cancer in someone younger than 20, and absolutely seen cancer in women older than 40, and many times don't see cervical cancer until age 60 or 70, in part because women come to me and say, "Oh, Dr. Heidari, I didn't know I still needed to be seen. I started to have abnormal discharge or watery discharge or an odor or bleeding that wasn't normal." And at that time, we detect cancer. And so I have several patients with diagnosis in their 60s and 70s with this. Squamous cell carcinoma begins in the squamous cells. So there's that squamous epithelium you can see on the outer border of the normal cervix. Adenocarcinoma or glandular carcinoma of the cervix of cervical cancer is a more aggressive cancer, and you can see those more internally. These are harder to sample with the traditional pap test due to their location more internally inside the cervix. So there are a couple different ways to screen for cervical cancer. Most commonly, women know the pap test. This is where their physician places a speculum inside the cervix to evaluate and look at the cervix. Then we take a brush and we collect cells from the surface of the cervix, and we look for abnormal cells. Obviously, this test is a subjective test, so it depends on the evaluator's ability to diagnose and evaluate abnormal cells. It has a little bit lower sensitivity. Clinicians who've seen cervical cancer or treat cervical cancer more regularly may have a higher sensitivity of detection. However, across the board, the pap test is a fantastic test. And so that's why its use is so ubiquitous and why its use is so widespread, not only inside the United States, but globally as well, because it's actually a very good test. And sometimes patients will have no result test, and part of that reason that the test may be resulted as a no result is that enough cells weren't collected during the collection process. And so the other test that we use is the HPV test. Similarly, we use a brush and we collect cells from the cervix, so that surface of the cervix, for the presence of various types of cancers that may be causing HPV. This has a much higher sensitivity in part of the way the specimen is processed in the lab. Okay. The overall rate of cervical cancer has dropped in the United States But unfortunately, adenocarcinoma, which is a more aggressive cervical cancer, has remained unchanged. So when we look at the timeline for development and major milestones in cervical cancer progression, a few that I'd like to note is that the Pap test, or the Papanicolaou test, was first introduced in 1950. And we see this link of HPV to cervical cancer in the 1980s. The FDA first approved the HPV test in 1999. And we started to have the Pap test and HPV testing become more available for women ages 30 to 65 years old. And the screening guidelines adjust for HPV testing at that time. The vaccine first became available in the US in 2006. And so at that time, the recommendation was to vaccinate up until the age of 26. So if at that time you were kind of on the cusp of vaccination, you may or may not have been vaccinated at that time. In 2009, the screening guidelines changed for no screening under the age of 21, in part because so many women will clear the HPV, and the screening and biopsies and recurring visits and invasive treatment has been shown to perhaps not be so necessary for someone so young, in part because they will likely clear the virus. And it's not so much a single incident of HPV or HPV virus causing the cervical cancer, but a persistent HPV infection leading to cervical cancer. And so part of that led in 2012 to lengthened screening intervals for all ages, as opposed to perhaps every 2 or 3 months, extending that screening time. So current cervical cancer screening recommendations are typically and have been age-based. However, depending on abnormal results, those will change with age and also change with the result itself. So depending on what the result shows, your recommendations may change. But for someone undergoing screening, age 21 to 29 is a pap smear every 3 years. Now, I want to make a couple caveats statements to that. It doesn't mean you don't need to see your doctor every year. It just means that depending on your risk factors, you and your doctor may decide that a pap smear at that particular visit isn't necessary. And so it doesn't mean you shouldn't see your doctor every year. So age 21 to 29, the American College of Obstetrics and Gynecology recommends every 3 years. Now, once the age of 30 is reached, you may consider co-testing. So that's a pap smear with HPV. Okay. And if that's normal, you may consider testing every 5 years. Now, this is the preferred method. However, if HPV testing is not offered or not available in your location, then you may do the PAP alone every 3 years and continue this up until the age of 65. And there's a huge caveat for the age of 65 that I want to go into, because we're seeing a higher rate in older women of cervical cancer, in part because women think, oh, I'm 65, I don't need to see the gynecologist anymore, I don't need to be screened, and really haven't gotten to those kind of specific caveats for adequate screening over the age of 65. The age to start is age 21. And screening should occur whether you've been vaccinated for the HPV vaccine or not. Okay, and so these are the recommendations we discussed, and some of this fine print has to do with the caveats of the testing. So here, a lot of people focus, well, age greater than 65, I'm 65, I don't need any screening. So no screening after adequate negative results. And you see there's a lot of caveats. There's that little S with a lot of caveats. And so I want to go into that. Well, what does that mean? So adequate screening means that you have 3 consecutive negative screening results. That means over 9 years, you've had 3 results that have shown no abnormal cells, okay? Or 2 consecutive negative co-testing results. That means over 10 years, you've had PAP with an HPV test, and both the PAP and the HPV test was negative. Okay. So if you're 65 and the last time you were seen was when you had your children in your 30s, that doesn't mean that you've been adequately screened, meaning that does mean you should consider a PAP test and should consider a conversation with your doctor about screening. Or you've had 2 consecutive negative high-risk HPV results. And that's when you can stop or consider stopping HPV screening. So we should use all the available tools to prevent cervical cancer. And part of that has led to cervical cancer being decreased in the United States in the past century. In part, we've discussed that screening. However, there remains significant disparities in both socioeconomic and resource poor areas. Screening technology has evolved and now includes high-risk HPV. And screening recommendations and guidelines are complicated, and not everyone's situation is the same. And so if you have had a history of an abnormal pap smear, then many of these recommendations that I have discussed don't apply to you and may not apply to you. And so really conversation with your healthcare provider and making sure that you're getting adequate screening and regular examinations are paramount and very important. The HPV vaccination holds promise to decrease the burden further. And part of the reason that we've also seen a sharp decline in cervical cancer is because starting in 2006, 7, really that rollout of the vaccination. Now, it did take several years for many women and men to be vaccinated. And now recommendations for young children to start the vaccination, in part because it's effective, more effective vaccination at a younger age, and also prior to sexual debut as well. Now I want to kind of move on a little bit to breast cancer, another gynecological cancer that women face. And we all have mothers and sisters and friends and so to the men in the audience, if you hear something that kind of sparks your ear, you can go ahead and kind of share that with the women in your life. So breast cancer is the most commonly diagnosed cancer in women in the United States and the second leading cause of cancer death in American women. And that's from the American College of Obstetrics and Gynecology. And this is just a diagram to kind of review a little bit by the Comprehensive Cancer Network, the breast, the nipple, and the lymph nodes. So lymph is a clear fluid and it drains from breast tissue into lymph vessels where it travels into lymph nodes. And most of the breast lymph nodes are located in the armpit or the axilla. Not all, but most of that breast tissue will be located in that area. And those specific lymph nodes are known as axillary lymph nodes. So how can we screen for breast cancer? So screening for breast cancer involves screening mammogram, and we can also use clinical breast exam, another reason to see your OBGYN doctor or your primary care doctor for breast examination. Screening mammograms and mammograms include picture inside the breast, and this is an X-ray picture. Now, the amount of X-ray exposure is low, which is part of the reason that our recommendation for normal screening mammograms is every year. But if you require additional pictures, that's okay too, in part because the amount of radiation exposure is very, very minimal and low. A computer will combine the x-rays to make a detailed picture of the breast. Now, if you require a diagnostic mammogram, this mammogram involves pictures of specific areas of your breast. So a diagnostic mammogram is typically obtained after a screening mammogram. And this is to look at particular areas of the breast that may have revealed abnormal areas or areas of concern by the radiologist. So this is a picture inside the breast. It uses x-ray as well, and a computer will combine the x-rays to make a detailed picture. Now, a diagnostic mammogram typically looks at specific areas of the breast that may not have been clearly seen on a screening mammogram. A bilateral mammogram is the name given to a picture of both breasts, so both the left and the right breast. And another imaging tool used to detect breast cancer or screen for breast cancer. So this breast ultrasound uses high energy sound waves to form pictures inside the breast. Okay, so ultrasound is good at showing small areas of cancer that are near the skin. I think we'll go ahead and save all our questions for the end of the lecture, if possible. Thank you. Sometimes an ultrasound or an MRI is used to guide biopsy or guide the way in which we obtain the biopsy. So an ultrasound can be used to help us biopsy breast tissue. We can also use an MRI to help guide biopsy of the tissue. And what is a breast MRI? So this is where we use magnetic resonance imaging. So these are radio waves, and they use powerful magnets to take pictures of inside the breast and the body. It's not an x-ray, and we use it in addition to the mammogram. So a contrast material is used to improve the picture inside of the body. These materials are not dyes, but substances that help light up the area of the breast so that the radiologist and your physician can see the abnormal cells a little bit more clearly and look for abnormal areas of the breast. There are many risk factors for breast cancer. Having a family history of breast cancer, ovarian cancer, or other genetic or hereditary cancers associated with breast cancer, ovarian cancer, like prostate cancer or Lynch syndrome or pancreatic cancer, can affect our screening recommendations. If you have a gene mutation that has been linked to breast or ovarian cancer, prior breast biopsies with certain pathology, so lobular carcinoma in situ or atypical hyperplasia, can change your risk factor for breast cancer and may make you at more risk for breast cancer, in which case your recommendations for screening or recommendations for follow-up of your breasts would change as well. Early menarche, so having your period earlier in life, increases your risk in part because of the exposure to estrogen. You have more years of that exposure. Late menopause as well, so having your menopause in your late 50s or 60s can increase your risk of breast cancer, in part, again, that prolonged exposure to estrogen. Nulliparity or not having children, in part because there's a stop in your kind of hormones that change or fluctuate. And so never having children also increase your risk of breast cancer. Long intervals between your menarche and first pregnancy, so children at a much later age. Menopause hormone therapy with estrogen and progestin. And so that can change your risk of breast cancer. Now, a caveat is decreased risk with estrogen alone, but I want to mention to you that estrogen alone, in terms of menopause hormonal therapy, can increase your risk of uterine cancer. So while estrogen alone therapy may decrease your risk of breast cancer, it can increase other cancers. So something to be cognizant there. Increasing age, not breastfeeding, certain ethnicities. Ashkenazi Jewish women have a higher prevalence of BRCA, or the gene associated with breast and ovarian cancer. They've been shown to have higher rates of breast cancer. Higher body mass index, so being overweight, or high BMIs have also been linked with breast cancer. Alcohol consumption, smoking, and dense breast tissue on mammogram. And part of the reason that dense breast tissue on mammogram is linked with an increased risk of breast cancer is because dense breast tissue is harder to detect, or it's harder to detect breast cancer in dense breasts. The tissue is dense, and so the x-rays don't penetrate at the same frequency, and so it's harder to pick up abnormal cells and harder to pick up abnormal tissue on dense breasts. And so the screening for dense breasts has come into question over the last few years. Do we couple that with an ultrasound? Do we couple that with a breast MRI to help us detect breast cancer? And those are questions that should be addressed with your healthcare provider or doctor. Prior exposure to chest irradiation, so if you've had a cancer of the chest at a young age, then you're at increased risk of breast cancer. So here we go into some of the recommendations. And you can see that the American College of Obstetrics and Gynecology has a slightly different recommendation than the U.S. Preventative Services Task Force and the American Cancer Society, and also the National Comprehensive Cancer Network. And part of the confusion, I think, amongst the community is that each of these societies has a slightly different recommendation. And I think it's a very important that you speak to your doctor so that you can have a shared and informed decision-making approach in which screening guideline you would like to follow and what makes sense for both your medical history and your family history. And this recommendation and these set of recommendations are for breast cancer screening in the average risk woman. And so if you're somebody who has those increased risk factors that I discussed on the previous slide, then these recommendations may not be appropriate for you. So the American College of Obstetrics and Gynecology recommends initiating mammograms at the age of 40. So starting at the age of 40, the recommendation, if the patient desires, is to start screening, okay? But by no later than age 50 should you start. So you may start at age 40, but by age 50, then screening should occur annually or every 2 years, okay? And so that depends on the risk factors, the clinical breast examination. You may offer the clinical breast examination every 1 to 3 years for women who are 25 to 39, and it's recommended every year for women over the age of 40. Okay. When do we stop mammogram? So we recommend continuing mammograms until the age of 75, but beyond 75, it should be a shared decision whether to continue or not. And part of the reason of the age of 75 is that one of the reasons to screen is to detect cancer. And why do we want to detect cancer? Ultimately, to prolong our life. So if we don't expect a life expectancy of over 10 years or greater than 10 years, then we may not want to continue mammograms after the age of 75. But if we're considering living beyond age, late 80s, 90s, even hundreds, then maybe we should consider screening a little past 75, in part because if we're able to detect a cancer and somebody's, a relatively healthy young 75-year-old, then they may choose to undergo chemotherapy, radiation, or surgery if they do develop breast cancer. But again, this is a very specific shared decision about whether to discontinue based on their health status and how long their life expectancy may be. Women at average risk of breast cancer should be offered screening mammograms starting at the age of 40. Women at average risk of breast cancer should initiate screening mammogram no earlier than age 40. Now, if there's a mass or a family history, this screening recommendation may change and it may be a different recommendation. If they haven't initiated screening in their 40s, they should begin screening mammogram by no later than age 50. And the decision about the age to begin mammogram screening should be made through a shared decision-making process with their provider. This discussion should include information about the potential benefits and harms of screening. So when we look at what are the harms and what are the benefits of annual versus biennial screening of the mammogram, we kind of weigh fewer breast cancer deaths with the life and the years that they have gained. Also, the risk of a false positive. So no test is perfect. And so sometimes mammograms may pick up areas that we think look abnormal, but they may be normal variation for that person as opposed to an abnormal cell or cancer. And so that person would undergo additional procedures and additional testing, additional biopsies that have risks. And so what are the harms of that? And unnecessary breast biopsies. Also, overdiagnosis of breast tumors that can lead to additional interventions, and weighing that risk and benefit. Women at average risk of breast cancer should continue screening mammogram until at least the age of 75. And age alone should not be the basis to continue or discontinue screening. Now, beyond the age of 75, the decision to discontinue screening should be based on a shared decision informed by the woman's health and longevity. Thank you again, and I open up the forum to any questions.